مساء الخير، أهلا بكم في هذا اللقاء، وهو بعنوان ميتا أناليسيز. يقدمه الدكتور هيثم جهرامي، وهو منتل هيلث ريسيرشر في مملكة البحرين. تفضل دكتور هيثم.
السلام عليكم. إن شاء الله بس يكون صوتي واضح.
تمام.
في البداية جزيل الشكر والعرفان مع الدكتور وليد سرحان على هذه الفرصة وعلى هذه المبادرة الجميلة حقيقة اللي قاعدين كلنا نستفيد منها. إن شاء الله most of my talk will be in English, but I thought to have a soft start بعد يوم طويل. قلت بعرض بعض الأرقام اللي تخلينا الآن نفكر why do we really need meta-analysis. I used Google AI search and I put, as you see, how many daily medical articles is added daily. Results كانت approximately 3,000 to 7,000 new medical papers. Actually, if we look at all of the databases, because I also peer review a lot of bibliometric studies, evidence suggests that every day is almost double this number that is being published among other languages than English. This is, of course, as you can see, it is only for English language papers. But anyway, even if we take the 3 to 7,000 new articles, this translates to one paper every 26 seconds. This means that the rate of publication is double the rate of suicide, which we know it is one of the biggest problems that we deal with. I would like also to remind my colleagues about the hierarchy of evidence that usually when we talk about papers, we escalate from basic things like case reports until we reach to basic studies like a cross-sectional case control cohort. And we always thought in randomized control trials is the gold standard for experiments. But as more we advance with science, now we are becoming to learn that meta-analysis is becoming the fuel of setting policies and the fuel of changing guidelines. But even the world didn't stop at this. And inshallah, my talk today will be focusing on meta-analysis. But the new trend is moving towards something called umbrella reviews. Because what will happen is when we have a systematic review or a group of systematic reviews and a group of meta-analysis in related topics that are not necessarily focusing on the same research question, sometimes they can have conflicting evidence. And this is why putting them all together in an umbrella review is becoming necessary. With that introduction being said, I think I can move to speak now about what is meta-analysis and its application to psychiatry and also to psychology. We have a lot of meta-analyses that are being published and used to set policies, but some of them actually having questionable results because they pulled results among all of the races without putting consideration for Arab race and without putting some of the elements for what can constitute different for our population. So inshallah, in this lecture, I would like to define what is meta-analysis, and we would like to highlight its importance in psychiatry. I will go over step-by-step methodology and how can we use actually existing meta-analyses, especially now that according to the latest requirement of Prospero that most of the registration rate to require the data to be open set. So if there is a meta-analysis that was published, let's say about the effectiveness of SSRI for patients with depression on controlling suicidability, it will be for worldwide results. But an Arab researcher can take that data set and rerun the meta-analysis only for Arabic studies and therefore can make conclusion if the results are comparable to the big population or no. We will talk a little bit about statistics and their interpretation, and I will give a very brief examples of real-world studies and their clinical implications. So what is really meta-analysis? Meta-analysis, the way that I usually define it, it is the step that is coming after systematic reviews. When we are having a large number of literature, we try to put it together in a summarized fashion. That way, we conclude with the results of all of the available literature about a specific topic. ناخذ مثال about something that عملنا إن شاء الله قبل فترة بسيطة. We took actually the data that studied disordered eating or eating disorders in medical students. It is one of the most vulnerable population, and we deal with them. They are under very high stress. They have shift works, and they have a lot of changes in their career. Globally, together, we know that cumulatively all types of eating disorders can constitute up to 3.5%. But when we pulled results from medical students' literature, we were surprised that it was almost 2 times. It gave us approximately 10%. So what is really meta-analysis adding to the science is 2 words that I would like to give: higher precision and higher confidence. It is basically to increase power, because when we are studying a problem, and some countries like Bahrain, as you know, it's a very small country with a total population of approximately 1.5 million. So when we contribute with a study, and when we compare it with a study that is coming from China, for example, the sample size in our studies usually become a fraction. This is why it is not possible to combine them and take the average, or to combine them to take the mean. If we take the mean, the Chinese average will overtake the Bahrain effect size, and therefore it will give a very confounding results. Another thing that meta-analysis is very good at is resolution and estimation. A lot of the times we find that studies having conflicting results. With one study, like study A, for example, say that this treatment is very beneficial. And we have another study that is from a better team, from a larger sample size, and it gives us a conclusion that this treatment is moderately effective. And sometimes we have studies that are good and studies that suggesting bad or harmful effect. So the power of meta-analysis is we combine them together and we have the whole picture. The term was introduced very early in the 70s by a statistician called Glass. And psychiatrists actually were the first group to adopt the term and to adopt the technique of meta-analysis. It got very popularized in the early 90s, and today it is becoming the fundamental cornerstone of setting any guideline, particularly for the big organizations that is governing healthcare. So why it really matters? Because in mental health, we have specific challenges. The first thing is the small sample sizes. Most of the studies that are running into psychiatry are limited to the number of participants. We are already dealing with a population that is very heavily in defaulting. They do not attend their own appointments, and therefore, usually with RCTs, dropouts are very high. Another thing that I want to highlight from this slide is the ethical data utilization. A lot of studies are generating data and they are analyzing it in a way that is proving their own perspectives or their hypothesis. And therefore, it might have some sort of bias or a redundant clinical views. So when and when not to use meta-analysis. We use meta-analysis for or in four indications, and we have one contraindication when we do not use it. I will start with when we do not use meta-analysis because it is easier. It is not suitable for rare topics or when there are very little number of studies, or if the studies are completely heterogeneous and synthesis would be invalid. Here I would like to highlight the suggestion from Joanna Briggs and the suggestion from Cochrane collaboration about what do we mean by the number of insufficient data. Practically, we can do meta-analysis with 2 or 3 studies, but their power will be very, very low. This is why recommendation of at least 10 studies to be included in order to have a validated meta-analysis. Now about the indication of when we use meta-analysis is when we have existing multiple treatment for a specific disorder. Let's say, for example, for PTSD, we can have CBT, we can have just behavioral therapies, we can have pharmacological therapy, and we want to see which treatment that is more superior. So here we can combine all of the studies, whether they are on the same intervention or on multiple interventions, and we see which one will be giving us the best results. Another indication is when we want to assess the treatment efficacy or identify risk factors for diagnostic accuracy. The third indication will be about the application of specific therapies or diagnostic markers. And it's very important to also highlight that is not all of the meta-analyses in psychiatry or psychotherapy are only about treatments or diagnosis. Is very important to highlight that a very large growing number now of meta-analyses is about prevalence data. So if we are trying to study something, I can see a comment. Are we taking a question now, or Dr. وليد, or we will take them
But
at
at
the
the end, it's better.
Okay, am I doing good, or I'm going very fast or very
No,
slow?
it's good.
Thank you very much. So we'll address all of the questions, inshallah, at the end. So a large number of meta-analyses is now actually about the epidemiology and the distribution of the disease. So the steps to conduct a meta-analysis, and here I want to highlight how can we use this into practice. The first step is because when we want to do meta-analysis, we're gonna deal with large number of the literature. This is why it's very important to have a very clear question. Here we use the framework that is known as PICO, P-I-C-O, or sometimes it's also abbreviated as PICO with P-E-C-O. This will identify for us our population, our intervention, our comparison group, and our outcome. I will come to explain each one of these in more details later. Then to do a meta-analysis, we need to perform a very good literature search. The recommendation is to have at least 2 databases, with PubMed or Medline becoming one of the essential, and the Scopus becoming the second recommended one because they capture the large number of literature. But because some of the psychological papers are only indexed in the PsycInfo or the Embase, it is recommended to also include as large as possible number of these databases. Here it's very important also for me to highlight that some papers are usually indexed in more than one database, and usually they will be eliminated during the filtration process. But because in meta-analysis we don't only deal with published studies, We deal with the gray literature like a master thesis, PhD thesis, or internal reports, or studies that are undergoing, studies that are now being published as preprints. So it is always recommended to contact key expert, key people to request further amount of literature. As with any study, we should have a very strict inclusion and exclusion criteria. And in meta-analysis, there is something called dual examination. So once we define the question, we obtain the large number of the literature, we try to eliminate the replication, we start to screen them for inclusion or exclusion. Here, two people usually blindly investigate all of the literature search, and they decide if each paper will be included or excluded. Priorly, before studying the actual topic, they should have an extraction question or extraction sheet. While they decide of inclusion and exclusion, they usually perform the data extraction. Let's say, again, I like this example about eating disorders in medical students. I would like to perform this meta-analysis again. So what do I need? I need to include the studies that focused on medical students and investigated the prevalence of a specific disorder, that is ED in this case. So what kind of factors that I would like to extract? I will take the country. I will take to start first the study details, the bio data of the study, or the metadata, if you like to call it. We will take the sample size. We'll take the number of people who have eating disorder. We will take the mean age of the population, the gender, and other factors. Later, we will be able to compute the prevalence for each study, and then we will be able to combine it all together. With the performance of extraction, usually we perform something called the quality assessment. Here we are investigating about how good each study was performed. Like some studies are including, let's say, I'm staying with the same example of eating disorder. Some studies will be asking medical students to fill a questionnaire or to fill a very brief unvalidated scale. So this one, I will give them a very high risk of bias because it is not very accurate to diagnose someone with eating disorder based on an unvalidated items or an unvalidated tool. Some studies will be given something like a moderate level, and these will be studies that have used a scale that is validated with psychometric properties like EAT26 or EDIC or any other available tool. But I will give a very low risk of bias or very high quality for studies that actually performed an interview with each student, that at least one psychiatrist, or even much better if two psychiatrists have met that student and confirmed the diagnosis. Post performing all of the analysis, we run a diagnostics to compute factors for heterogeneity. Heterogeneity, we want to see here how studies are similar or how studies are different. It will not make sense to compare apples with oranges. So therefore, if I take the studies that have used the questionnaire, maybe their prevalence here in eating disorder will be 10%. But if I take studies that have used a psychiatrist, their prevalence rate will be 3 or 4%. It's a big number in the prevalence statements. So when we combine them together, it will give something like 7%, but it will give me an alert of heterogeneity that is called I square, or the measure of heterogeneity. There is at least 12 heterogeneity measures, but I square is the most common one. And finally, when we complete the meta-analysis, we try to interpret it in terms of goodness of fitness, how reliable we can use this meta-analysis for setting guidelines. So defining the question, as we said, we used PICO, population, intervention, comparison, and outcome. We want to study the effect of transdiagnostic apps on depression and anxiety symptoms in adults compared to wait list. Here, our population will be adults with the MDD or MDD and the anxiety, and our intervention will be diagnostic apps. Our comparison is wait list or wait of usual, and usually we decide what we will be measuring in terms of symptoms. So symptom reduction, we can take a mental state exam, we can use data from one of the available questionnaire in all of the studies, or we can use a mix of both. This will be dependent on what is the norm in that specific field. We spoke about the literature search. We said more than 2 databases are encouraged. And I forgot earlier to mention that we usually also search for the Cochrane library, because Cochrane collaboration is actually trying to add systematic reviews and meta-analyses on a large number of topics on specific times. When we perform search, I would like to give you here also a hint about how can we capture sensitive versus unsensitive search strings. Well, the order of the search usually doesn't matter. So for example, if I search for Dr. وليد Sirhan, or if I search for Dr. Sirhan وليد, I will end up with the same number of results in any search engine. So sensitivity is not order specific, but it can be specific and non-specific, or sensitive and non-sensitive. Here we use and or in order to make the search more sensitive. So I would like to continue with the example of Dr. Prof. وليد Sirhan. If I put Dr. وليد Sirhan in any search like PubMed, I will get a specific number of papers. But if I add and Jordan, I will have a smaller number of hits. And if I add and psychiatry, I will have a very smaller number or maybe a unique records. Here where we can define our search in order to be matching with our PICO. So back again to the previous slide, if you can recall it, when I said the people with the anxiety or people with depression, if I said major depressive disorder, or if I said depressive episode, or if I said depression or depressive, if I use depression or depressive, I will cover both, so it will be more sensitive. This is a typo. This should be gray literature. As we said, we take dissertations, we take conferences, we take proceedings, and we take also preprints. If there are supplementary data or supplementary tools, it should be available and should be published. And I encourage Arabic researchers, particularly junior researchers who are interested in meta-analysis, to go and look for supplementary sources of existing meta-analyses, because usually they will find that there are subgroup of data that is actually from the Arab world, but it was not previously analyzed. This is why they can run a specific or sensitive analysis on this population to have Arab region results. I would like also to give advice that usually when we think about AI, we think about ChatGPT, we think about Gemini, but there are 2 important AI assisted tools, one called Ryan and one called Covidescence. These are available free of charge in order to facilitate and to help with the collection, extraction, and the inclusion and exclusion of any of the studies and the meta-analysis. In order to keep a very good documentation strategy, there is a very important guideline. It's known as the PRISMA, the Preferred Reporting Approach of Systematic Reviews and Meta-Analyses. This guideline is the recipe for doing a very good or a very high quality meta-analysis. So now let's talk about some of the statistics. When we are collecting statistics, usually we take four elements. We take effect size, we take the sample data, we take variance, and we take moderators. The effect size, as you all know, these could be the mean, like the mean score of PHQ, the mean score of JAD-7, the mean score of Glasgow Coma Scale or Glasgow Antipsychotic Scale, whatever scale you would like to take. It can be an event rate, so like a percentage, but it can be also the p-value if the results concluded in that study was significant or non-significant. We have to take data about the sample size. Here we collect the sample size, the demographic, and the diagnosis detail. With effect size, sometimes we need error data, so we collect variance. And most of the time we take a standard deviation or confidence intervals because they are the most common used in the literature. Lastly, we would like to do something called also meta-regression, or we see how the studies differ based on moderators, like the year of the study, if there is a medication status, duration of the status, or even as we discussed, quality. We take the data of all of the studies, we put them into Excel or into directly RevMan, which is a Cochrane standard for extraction, or other commercial data bases. For risk of bias, there are two important tools that we should be all familiar with. And actually, for those who are acting as peer reviewers, I also suggest that they download these tools and they can use them when they are examining or when they are performing peer review activities. Because risk of bias is like performing a post-publication peer review. So for RCTs, we use the Cochrane Risk of Bias ROB tool, and this is giving us a score about how good is the study. For observational studies, like non-experimental, we can use the Newcastle Ottawa scale or the Robbins scale. These are the two important tools that I can suggest here. It's very wise also when we perform meta-analysis is we do something called the sensitivity analysis. Here we can do sensitivity analysis in two ways. The first one is we remove one study at the time. So we perform a meta-analysis with the 20 available studies. But when we do a sensitivity analysis, we will remove study number one in the first time. And we will see the results. Is it same or it's changing? And in the second round, we will remove the second one and so on. Another way to do sensitivity analysis is we remove a specific groups or we remove a specific people. So for example, if we are doing studies about autism, and we are interested about the effect size of change in social skills, we can remove those who have dual diagnosis of autism and let's say of mental handicap or mental intellectual disability. In statistical modeling, and I know it's the end of the day, so I will not take a long time about this. We have two types of modeling. We have something called the fixed effect model. This one is assuming that there is one effect size. There is one true effect size for all of the results. This is usually discouraged and very rarely used in medicine. In medicine, we assume that true effect size is actually dependent on a number of population. This is why we always use the random effect model results. Fixed effect model results, if it's available, it's for entertainment purposes. Heterogeneity usually minimum in this, but this is giving us a more of real life data. For data software or database softwares that I can recommend, and these are all the most of these are free of charge. They are open source software. The first one is R, statistical package with metaphor package being the main software in use for meta-analysis. The CMA or comprehensive meta-analysis is much easier to use, but it's a very expensive data software with very low visualizations. It doesn't give much power as the R. We have RevMan, which is a free of charge, but this is only restricted for Cochrane reviews, and therefore it is only suitable for experimental studies. So if I want to examine the prevalence data, or if I want to examine hazard ratio data, or if I want to examine correlation effects, RevMan will not help much. The last one that I can recommend is JASP or JAMovie. Both are brother and sister, and they are using R but with visual interface for those who have experience with them. Now about effect size. Usually we use the Cohen D effect size, and here we have 0.2 as minimum, 0.5 as moderate, and 0.8 as large. It's very important for me to actually highlight something that many people are sometimes not fully aware of, is that Cohen's D, Hedges G, they are also referred to as the standardized mean difference or SMD. The effect size can change based on what we are interested. This is becoming hardcore statistics, so I'm gonna have a very quick skip over this. For the heterogeneity, we have this measure, which we already discussed earlier, the I-square statistic, which is telling us how studies are reliably giving us the same conclusion. So it is defined as low if it's less than 25% of heterogeneity. If it's 50% or more, it's known as moderate heterogeneity. And if it's 75% plus, it's a high heterogeneity, and results need to be interpreted with very high cautious. So once we have high heterogeneity or moderate heterogeneity, and most of the time, 99% of meta-analysis heterogeneity is more than 80%. Here, we have to do subgroup analysis. We have to compare male patients versus female patients, male patients that are from Arab race, compare male patients that are from other races. We can do meta-regression to investigate the effect of dose or treatment or age or any other factor. We can do influence analysis, the leave one out sensitivity analysis. We remove one study at the time, as we agreed earlier, or we can report other metrics to see how the heterogeneity factor will go. This is what we get in meta-analysis, and this is actually called the forest plot. In forest plot, we have the midline or the line of no difference, and we can have studies that are being scattered on both sides. So Let's say studies that are on the right-hand side is suggesting that this treatment is effective, and those are on the left-hand side suggesting that this treatment is not effective. Clearly, by eyeballing results, most of the studies agree that this treatment is not effective. But even for those who are saying that this treatment not effective, they have a significance test or a 95 confidence interval over crossing the line, suggesting that this treatment can be actually generally not beneficial, but sometimes it can give results. Some studies like this will give clear cut that this treatment is not effective at all. This one is giving this treatment is not effective at all and with very high power. The larger the line, the red line or the confidence interval is indication of sample size. So if the sample size is large, we have a very small confidence interval. But if the sample is narrow, we have usually very high error rate. It's not showing here, but there should be a diamond shape which give us the complete effect size for this study. So it is the numerical analysis. We already discussed subgroup analysis and identifying outliers to see which one. I'm not going to speak about funnel plots because this is not being used anymore except for visualization of heterogeneity. Some errors that we face with meta-analyses that I would like to quickly discuss with my colleagues is publication bias. The meta-analysis is only as good as the studies that are included in the meta-analysis. So if we fail to include studies based on specific language or studies that are not abstracted and available in the databases. And for example, I know that in Arab world, we have a lot of studies, but when they do meta-analysis, they do not include databases that are Arabic speaking, like I think Al-Manhal. They use the midline, they use the PubMed midline, they use Scopus, Web of Science, but not localized databases. So this will give a publication bias. Another error we get is that smaller underpowered studies usually reporting higher effect sizes compared to the larger because of the error rate as we discussed. So this is why we need both small and large studies to be included. And it's very important to highlight outcome reporting bias. So, for example, if we talk about antipsychotics, we can say about their efficacy, we can say the improvement in symptomatology, but we can omit some of the side effects. We can omit the metabolic syndrome that they can induce. And reporting actually both the good and the not good parts will be making it more balanced. Another bias we have is the ecological fallacy that assumptions based on meta-analysis should not be generalized to individualized patients. It should be only available for guidelines, and the individual physician is responsible for the customized care of the patient. The last one is data dependence. As we said, there are errors in studies, there are retractions from papers, there are omissions, and there are corrections. So it's very good to do a meta-analysis and after time to do updated meta-analysis, because some studies will be available, some studies will be added, and unfortunately, some studies will be also removed. to quickly now to talk about grade, and this is actually becoming now a requirement by the top impact medical journals, is we perform something called the quality grade to say if this results of this meta-analysis can give high certainty or a very low certainty. Usually for a grade, there is another tool. It's also called the grade. It's available on the BMJ website. It can be actually done directly online, and this will be to evaluate the quality of the overall meta-analysis. Another very popular tool to be used here is the MSTAR. Now I would like to talk to you a little bit about umbrella reviews, because umbrella reviews will be actually focusing on the grade quality of the meta-analysis. And after that, it will recombine the high certainty meta-analysis alone and the moderate and the low certainty and very low certainty alone in effect size. These are some of the examples that we already talked about. I think I can only show here the results, and therefore we can have a quickly conclusion on how to interpret meta-analysis. We are studying here in one of these meta-analyses the change in functional brain changes post treatment for patients with depression. And here our endpoint or our outcome is hippocampal volume, the effect size or the Cohen's d or glass hit for therapy is 0.5, almost 0.45, and for control is 0.05. It's clearly showing that therapy, whatever therapy here, whether it's CBT or SSRI or whatever, we decided to investigate, is performing much, much better, and it is still within the moderate effect size. Because if it's range below 2, it is low. Below 5, it's considered as 5 to 0.2 is considered as moderate, and between 5 and 0.8 is a large effect size. Actually, large effect size can go to 1 or even 10. I'm not going to bore you about more of this, leaving more time, inshallah, for questioning. This is another example that you can have a look in your own time. Now about my suggestions, because actually our team has published a lot of meta-analyses, and I can share some of them, shared in the past some on the WhatsApp group. For good care for a very high and meta-analysis, I would like to give you these suggestions and these sources. Well, the first thing is to make sure that it's PRISMA compliant. So using the PRISMA preferred reporting approach of systematic reviews and meta-analysis will guarantee a very high-end meta-analysis. For evidence-based planning, I suggest to use the Cochrane Handbook. I suggest to consult also the Campbell, Joanna Briggs, and the Cochrane training. They are all available open access and free to attend. And for those who are interested in the mathematical modeling, there are a lot of online tutorials. There are a lot of pre-advanced codes available for meta-analysis for packages like Metaphor and Meta. These are available in high quality databases like GitHubs. Two twists that I would like to share. One is known as network meta-analysis, and one is called the IPD meta-analysis, and I will make a conclusion after this. In network meta-analysis, we are usually investigating a group of multi-arms. So we identify which treatment is actually superior. So for example, if you are investigating the effectiveness of pharmacotherapy for depressive disorders, you would like maybe to compare SSRI compared to SNRI or another class of antidepressants. In IPD meta-analysis, we do not actually extract data, but rather we are inviting those who performed the previous studies to join together in one collaboration, and we reanalyze the data in a meta fashion. So, for example, if I performed a study about suicide in Bahrain, about the prevalence rate and the risk factors, and there are another studies that available, I think we can bring all of our data together and compare Bahrain versus Jordan versus Saudi Arabia and so on. We already discussed about the use of AI, and I remind you of both Ryan and Covidians. I will be available to take any questions. I know this was very quick, but this was only an eye-opener on the basic steps, the basic way to read meta-analysis and outputs of meta-analysis, and how do they change our practice. Thank you very much for listening. I will stop now. I will share all of these slides. I will share all of the available resource I have, all of the web links over the WhatsApp group. So Dr. وليد, if there is anything
شكرا
you
شكرا
advise.
جزيلا على هذا العرض الرائع. وأكيد يعني أي مصادر بتزودنا فيها بتكون بتساعد، خصوصا احنا الهدف to have more research coming up from the Arab world. دكتور نزار تفضل.
Yes. Thank you very much, Dr. وليد, first of all, for the series of lectures, and congratulations for the UHA staff member for the clinical psychology. This is on behalf of everyone else. And also thank you for putting my name on my camera. Unfortunately, I cannot do that. You do it every time. Thank you very much. Thank you, Dr. Haitham, for this beautiful lecture. And it is highly informative. It is something that most of us are deficient at, unfortunately, because most of the programs of postgraduate studies in the you called it the Arab world, I call it the EMRO region, the East Mediterranean or probably North Africa region, are deficient in basics training in this subject. Therefore, the lecture is quite enlightening and informative. I've got a couple of questions. Before that, I just want to make an analogy. This is a comment rather than a question. The process is just like a milestone. It started with case studies, then randomized control studies, and then systematic reviews. This is adolescence until now. And then meta-analysis, this is early adulthood, and now the umbrella reviews are grown-up people like yourself. Of course, when it reaches us, it's completely different. We don't know about that. Now, my question is really using all these skills that you have, and of course, when I say you, I mean people like yourself also, and looking at all the theses and postgraduate studies that are conducted in this region, in this region or in this part of the world, that are only put on the shelves of universities, and they are not used for analysis or for whatever, because I know there are two different systems. Is there a way, of course, today we are living in the AI era, is there a way where we can bring all these theses out of those shelves and use them, because I'm sure they contain a lot of data and information that are helpful for and practically useful for our region rather than the Western region. And thank you again for the lecture.
Yes, thank you very much, Professor Nizar. I think, yes, I agree with you. The gray literature is very important, and gray literature can focus actually on both the thesis, the dissertation, but it can also include actually the conference proceedings that usually we are very rich in this part of the word, but we do not actually document them. I think, Prof. Nizar, in order to best make this available, we should encourage young researchers, we should encourage academics, we should encourage also academic institutions to make it mandatory to deposit their abstract at least and their keywords in order to make it visible into an open data source. I will talk to in Arabic a little bit because it might be easier. في البحرين عندنا نظام for those who complete a master or a PhD or a postgraduate is that they have to deposit their thesis into the public library. But who goes to the public library now? Nobody. But if we, for example, upload the abstract only on ResearchGate, or we can upload it to Open Science Framework, or we can upload it to somewhere that it is not beyond the peer review jurisdiction. Because as you said, the world is now moving very fast, and now we are not waiting for studies to be published. We can have it pre-published and available in our hands. So my suggestion, my humble suggestion, particularly for policymakers, for head of departments, for key faculty member, is to encourage their students, to encourage their peers, is to put their information on open platform. Open Science Framework, OSF, and ResearchGate are very good sources that I can suggest. This will make it available not only for the Arab world, but only available for the global readers worldwide. I hope I answered your question, Prof. Nizar.
You absolutely did that. In fact, most of the universities nowadays are making it mandatory, whatever you are saying. And in fact, the system has changed. In the past, it was only a thesis. Nowadays, they don't grant the PhD unless you publish a couple of papers. And of course, these papers are published internationally. So yes, what you are saying is correct. But what I meant really, partly, are the old theses and the old research work that was done in the past, and it was not uploaded. This was my question, if there was any way, or if there is any way of making use of AI to really dig into these theses and use them internationally.
Yes, thank you, Prof. Nizar.
Thank you.
في سؤالين من الدكتور عزام في الشات.
هم مش سؤالين، هو كانت ملاحظة. مساء الخير دكاترتنا و our mentors، وشكرا للدكتور جهرمي من البحرين. It's a dry subject and he made it less dry, at least for me. Statistics has never been a strong point for me. My question was because this umbrella review thing, I think it's a new thing, and circling back on what Professor Nizar did say, we do have a lag in these subjects. And I remember starting my training here in the UK, we had a weekly academic meeting where trainees needed to present either a complex case presentation or a journal club review like what we do here. And I remember how hard was it for me to make my first lecture about a meta-analysis of a single antipsychotic versus multiple antipsychotics. It was an interesting, it was an interesting subject at that time. But anyway, how can both the meta-analysis and the umbrella review contribute differently to evidence-based practice in your opinion? And which one would you see is more pivotal in certain fields or aspects of psychiatry?
Yes, thank you very much, Prof. Azzam,
I'm not a professor. I'm a normal doctor.
thank you very much, دكتور. والله أنت بروفيسور، كلامك حلو كان في البداية. شكرا على راسي إن you think this was a good talk. Actually, I will use, I don't want to be egocentric, but I would like to use these examples because these are I'm very familiar with. So this was very close to my heart because this was my first meta-analysis about eating disorder, the one that I talked to you all. Can you see my screen?
Sure.
Yes, we can.
Yes, so this one was about the eating disorders among medical students. And when we performed the search, we did the analysis, and as I told you, we obtained results that was double the expected for normal population or healthy population or the general population, if you like to call them. But this answered because it's a systematic review and meta-analysis, it's a SARMA, it answered the very specific issue, which is eating disorder. I am one of the most interested and the most researched persons in medical students. So we actually took this level up and we did an umbrella review of all of the psychological and behavioral symptoms in medical students. So you can see now when you are looking at an umbrella review, the scope is becoming more breadth. So first it was focusing on eating disorder. Here we looked for all of the available psychiatric and behavioral symptoms. And if we can look at the results, we can see that the pooled prevalence rate for everything was 30%. And then we can see for sleep problem, it was this. For burnout, it was this. For anxiety, it was that. For depression, it was this. And for eating disorder, it was 10%. And lastly, for suicide or whatever endpoint we are interested, it was that specific number. So how do they contribute in turn? I think systematic reviews and meta-analyses are very good in addressing a very specific arm. Umbrella reviews are very good in addressing multi-arms. So if we are interested in more than one endpoint, the answer is an umbrella review. It's not a systematic review. I hope this explained it using a real life example.
No, I know the concept from kind of what you did. Your lecture was very enlightening for me. I did kind of got the gist that with umbrella reviews we're answering more wider questions or kind of a wider intervention than with systemic. And I think I've kind of wrote it at first that with meta-analysis we're usually answering the narrow questions where we put the PICO and we try to see a specific or narrow aspect of it. But I'm just saying, moving on in the future, do you think one will have more advantage over the other when it comes to certain fields of psychiatry?
The thing is, there is an advantage and disadvantage of both. Like if we will combine everything in one umbrella review, some information will go missing because we will not be available to adjust for the multiple confounders. And the confounders is a big issue in meta-analysis. Usually they give you a very high heterogeneity. Usually they give you a very large effect size that sometimes you even question the viability of the concluded meta-analysis. So for example, this is something that I actually worked with a couple of colleagues, and we plan to take this to the scientific publication very soon. I'm a very big follower of the metabolic disturbance post antipsychotics. And with one of the umbrella reviews that we are actually ongoing now, we found that the prevalence rate is reaching 75%. That's mean that regardless to the change of a class, whether it's first or third or second or even moving now toward the third antipsychotic generation, we still deal with 1 out of 4 people ending with premature mortality, because that will be the ultimate end points. So the umbrella review is telling us how is this working globally, how it doesn't work, how does it work with the total people, but it's still lacking the element of specificity of for only second generation antipsychotics or monotherapy or polypharmacology, or if there is another treatment. These issues will not be addressed by umbrella reviews because you are already dealing with the effect size that has been already combined.
اوكي اوكي makes sense. شكرا دكتور جهرمي.
في سؤال آخر من الحضور أو تعليق؟ تمام. on time. شكرا جزيلا دكتور هيثم على يعني هذه الإضاءات الجميلة، وأتمنى أن تشاركنا بعض هذه الأوراق والتطبيقات والبلاتفورمز. إن شاء الله سيستفيد منها الباحثين في كل الدول العربية.
الله يحفظك إن شاء الله بروف.
تصبحون
شكرا على هذه الفرصة.
وهناك
وأنتم بخير.
محاضرة أخرى للدكتور هيثم الأسبوع القادم عن سايكومتري، فترقبوها معنا. أهلا وسهلا. تصبحون على خير جميعا.
تصبحون على خير
الله.
دكتور وليد والجميع.
شكرا، مع السلامة.
شكرا.